Glacier Bank's totally free checking saves you both time and money. Visit your nearest Glacier Bank office today. There's a convenient location near you. Glacier Bank, member FDIC, and an equal housing lender. Joining us this morning, we have two surgeons, one here in the studio and one who will be calling in the studio with us, Dr. Doug Berglund.
Yeah,
Hey,
good
thank
morning.
you very much.
Good to have you with us. This is the time of the year when you guys in the ER start getting real busy.
You are exactly right. We track that every year, and it's interesting. The population just explodes in the valley over the summer, up to sometimes over 1 million visitors. They say
Really?
It's crazy, and of course the ER gets very busy. We usually have about 1,200 visits a year. Patients, trauma patients in the ER, 800 of those are admitted, and the majority happens in the summer. It really ramps up
1,200.
per
So
year.
let's see, that would be about what?
About 3 or 4 a day.
All right,
Yeah,
on an average.
on an average.
And about half of those wind up in the hospital.
Yeah, 800. So we have a lot of trauma admissions. It's a big part of our hospital work here.
Define trauma for us.
Yeah, so anytime like people, basically when you bump into something or you fall or you're in an accident where your body's going fast and it slows down really quickly, that's trauma.
Okay. Now, since it's a busy time of the year, we have a lot of visitors here. Are they different kind of traumas than we see at other times of the year?
Yeah, exactly right. So still the majority of trauma that we have is what we call blunt trauma, as opposed to penetrating trauma. Penetrating trauma would be something like, a gunshot wound or a stabbing or when some piece of farm equipment goes into your body. But majority is blunt trauma, where people fall, they're in a car accident, they wipe out on their motorcycle, they're climbing and they fall. That majority.
Interesting.
Dr. Steve Satterly is joining us. Good morning, Dr. Satterly.
Hello, sir. How are you today?
Good. So we've got our two surgeons here now, and we're talking about summertime in the ER. And what is your experience during the summertime?
Go ahead,
Oh,
Steve.
I got to echo what Dr. Doug Berglund's saying. Here in the Valley, I would say motor vehicle trauma is probably the most common. Unfortunately, some of that is associated with driving under the influence. I would say that's often hand in hand, especially with a lot of tourism in the Valley. And then, unfortunately, sometimes people still aren't wearing their safety belts, which does have a dramatic effect on the trauma burden in the ER.
Here's something I've always wanted to ask. If somebody is got a lot of alcohol in their system and they show up at the ER and they've been severely injured, how does that complicate your treatment?
Well, right away, it makes it difficult from a confounding factor. The symptoms or clinical findings you find, oftentimes alcohol levels will be high enough that people can't either tell you that they're hurting somewhere or they honestly don't really feel it. So that can make it difficult immediately. Following that, sometimes people have withdraw from alcohol a couple days later, and that can definitely make their care difficult as an inpatient.
Well, if they have a lot of alcohol in their system, what if you have to do surgery?
It typically doesn't affect what we have to do with surgery. Generally, if we have to take someone to the operating room immediately from a trauma standpoint, what we're trying to do is damage control surgery. And alcohol, I would say, typically doesn't have a significant effect on that unless it's at extremely high levels, and then you're going to have some cardiac abnormalities associated with that. But I've actually not seen that personally.
Okay, they're already anesthetized a little bit. Is there any complication with anesthesia then?
Yeah.
Not necessarily. They may be more difficult to wake up later on, but that's again that goes hand in hand with the level of sedation that they're already at, right?
Yeah, okay. But that was always a question I always wondered about. If somebody's comes in, or DUI, for example, and they're severely injured. So that helps us understand, at least that doesn't stop you guys from moving forward with treatment.
Yeah, exactly
No.
right. You know, Steve
No,
and I
but-
review all of the trauma cases, and it's interesting. Even, you know, car accidents for sure, driving while intoxicated is a big thing, but even people at home, we have a lot of people that fall and break a hip or strike their head. It's interesting how our elderly population, many of them are using alcohol, which is a kind of a sad story in our society, you know,
Yeah.
really. It contributes quite a bit to our trauma registry, unfortunately.
Oh, boy. We're talking with Dr. Doug Berglund and Dr. Steve Satterly, both surgeons at Logan Health. And I want to talk about some of the things that we are doing, the activities that we do that can get us into trouble and wind us up in the ER. We'll do that after this. And today we're talking about the ER. We have two surgeons from Logan Health, Dr. Doug Berglund and Dr. Steve Satterly. I want to ask both of you guys why you chose surgery as all the things you can do in medicine.
Yeah, go ahead, Steve.
Oh, thanks, Doug. Well, that's a great question. So I actually grew up in the Valley. Kalispell's my hometown. I was born in Missoula. Came to Kalispell when I was 11. Never thought I would be a doctor, so I kind of came into it, I guess, as a function related to my interests and ability. So I was more of kind of led to it, I guess you would say.
Just the whole concept of, you know, cutting into somebody.
My wife always tells me, you have a weird job.
Yeah.
Yeah. How about
Yep.
you, Dr. Berglund?
Yeah, same kind of thing. A bunch of series of events that happen in your life. You know, I was actually started out as kind of a math major. I was kind of a math nerd, and I thought I don't want to sit at a desk the rest of my life. My brother was going into medicine, so I thought, well, I could do that. So there, switch gears, and then I thought I was going to be an orthopedic surgeon. You know, bone broke me fix. But I found out the general and trauma surgeons, and I do mainly colorectal surgery now. But I thought they were kind of the smartest guys in the hospital, and I thought, I'm not one of those guys, but I'd like to be one of those guys.
Okay.
I think the ability to heal. I can't do what you do. There's just no way I could do it. I just don't have it. But I do kind of. I wish I had the ability to heal, and it must be just a very powerful feeling that you have, that you can actually bring somebody back to health. Even somebody who is literally clinically dead, you can bring them back to life.
Well, I think Steve's probably better at that than I am, but it is a humbling thing. It really is, to be able to help people out. And you know, there's never been a day where I haven't not wanted to go to work. It's really a rewarding job to help people out in their life. You know.
Well, Steve, how do you feel about that?
Well, actually, I would echo that sentiment. You know, having spent 24 years in the military and doing a lot of civilian trauma with some of our military civilian partnerships, I can tell you, you know, when people come in and they're looking to you to save them, or perhaps, you know, they've already at least physically started to die in front of you, it can be a very humbling thing for us to try. But that's our job. That's our calling, is to try and save people no matter what. So it's a very humbling but rewarding calling at the same time.
Well, I never got past advanced first aid, but being able to help somebody who's in that situation until, you know, more qualified help comes, I find that to be very satisfying.
Yeah, you know, we are so lucky to have Steve come on board. Steve's been with us about a year now. He's finishing up in the Carolinas with his stuff with the military, but he has just totally ramped up our trauma program in this last year. And we're very fortunate to have him. He's going to be with us full time now, and very lucky.
Both of you gentlemen are listed as surgeons. You're in the ER. Does it often, is surgery immediate, or is that another stage and separate from treating the trauma?
Yeah, go ahead, Steve.
Thanks, Doug. Oftentimes, when we respond to the emergency department, Doug or myself and colleagues, we're doing the immediate evaluation, usually in line with American College of Surgeons, ATLS, and that's Advanced Trauma Life Support. And what we're trying to do is find the immediate problems that can cause someone to pass away immediately. So oftentimes there will be procedures that we do right off the bat as soon as someone comes in, or we're giving blood, trying to replace lost blood with transfused blood, and then it's a question of whether or not we need to go to the OR. So we're not actually doing surgery in the emergency department. We go up to the OR for that. But you're right. A lot of the evaluations happen in the ER, and sometimes we do have to do surgery right there to save someone's life.
So let's talk about what we are doing here that gets us into trouble. Hiking, biking, boating, riding ATVs, working outdoors. What sorts of injuries do these sorts of things produce?
Yeah, what I always think about, is that, don't go skydiving without a parachute. Don't go deep sea diving without scuba gear, and, don't motorcycle naked.
Yeah.
So, we got to have adventure in our life, right?
Right.
But wear the proper equipment, be reasonable, don't take undue chances. Those are just some of the just very reasonable things that we can do to prevent injury, especially for young people. Wear your bike helmet, wear your motorcycle gear, be careful. Watch out for others. Don't get mad at people on the road. Give them the right of way. All those just simple things to think about.
Well, that's really the whole idea of the preventable things. But, there are other people on the road who may not share your your
the guy that rides
preparedness.
down the road with a loaded pistol looking for somebody who's going to cut him off. Yeah, exactly right.
Well, it's interesting. Years ago, they called them accidents. And I never thought I'd be in an accident until I got hit head on. When I was like 19, and I'm going, I didn't plan for that, So accidents can happen to anybody. What should you do as a victim when that happens? How can you lessen shock and those kind of things until emergency services gets there?
Yeah, go ahead, Steve.
Great question. So first of all, I guess if you're actually conscious, sometimes people have a traumatic brain injury, and there's not a whole lot they can do for themselves. But certainly, if you're a victim or you're part of a crash or see somebody, the best things you can do is call 911. Right away. After that, like Doug says, try and use your common sense. Don't try and be a hero if there's something that could cause yourself or someone else more injury. Following that, you're talking about more advanced, almost kind of life support type skill set that our EMS and medics in the military know. And if you want more information on that, we can certainly provide that.
I had a compound fracture in my leg from an automobile accident, and I remembered from health class, which was only a couple of years before, that one of the dangers is going into shock, and so I scooted across the seat and left my legs elevated while I was down on the ground. Was that a wise thing to do?
Yeah, exactly right. So, one of the things that immediately that can be life-threatening is blood loss, right? So one thing that you can do is, like with a compound fracture, means that the bone is protruding through the skin. If there is blood loss from that, first of all, straighten the leg, pull it out, and then also if you see bleeding, just put pressure on it, just hold it as hard as you can. The other thing is tourniquets. There was tourniquets were in vogue, now they're not, then they weren't in vogue, now we use them again. A tourniquet basically is put a wrap above where the bleeding is and then just super tight wrap that around the leg to get the bleeding to stop. So either direct pressure or tourniquets can save a person's life.
All right. Dr. Doug Berglund, Dr. Steve Satterly, our guests, and maybe some preparedness for when you go to the ER and maybe when you're going on your own power. We'll talk about that after this.
couple of Logan Health surgeons, Dr. Doug Berglund in the studio with us, Dr. Steve Satterly remotely. He said he's back east doing some service time. Huh?
Military stuff, yeah.
Yeah. So anyway, what I wondered was we've talked about EMS type arrivals at the hospital, but how do we define the difference between something's wrong, should we go to ER or to a walk-in clinic?
Yeah, go ahead, Steve.
Thanks, Doug. I would say the acuity is the most obvious. I mean, oftentimes we see plenty of people come in, a day or two later, and that chest pain never quite went away after getting hit from behind or something like that. And oftentimes we find out later they have some rib fractures. And so, it's really, again, this, like, Dr. Berglund was saying, it kind of goes to common sense. If you're really hurting, or you're still at the scene, just call 911. Don't take that chance that something is not happening, I would say. I mean, you can have a blunt organ injury like your spleen or liver that's fractured internally, and you just wouldn't know until it's too late. So in the acute setting, I would say, a little err on the side of caution and call 911 or have EMS come get you, get evaluated. You may be a trauma activation, you just didn't know it. That would be my advice.
Okay. I had a fall on the ice, got a hematoma under my arm as a result of it, and it wasn't bad at first, and I'm sitting around, and then my wife gets home, and I go, well, wait a minute, I'm black and blue all over here, and I was on blood thinners. I thought, maybe that's not good. We better go to ER.
Yeah, he's a frequent flyer to the ER.
I have a credit card for the express lane, I guess.
Yeah, always chest trauma
Well,
like
that's
that.
That's definitely a consideration, especially over the age of 65 and on blood thinners. I mean that automatically increases your risk for having some issues for sure. Yeah.
So as far as getting there on our own power, like sometimes we can just drive in with something we're not necessarily have to have medical professionals bring us in. What sorts of things can we prepare for an ER visit?
Yeah, so
sure.
Yeah, go ahead,
Go
Steve.
ahead, Doug.
Go ahead. You can go, Steve.
Well, the ER physicians down there are fantastic, and we have some great nurses, and they're very busy. So when you walk in or roll in, whatever the case may be, you're going to get triaged. So they take your initial vitals and kind of put you in a certain category, and and going off of those vitals, that's something that is going to either put you at the front as more acute than someone else. So, like you say, sir, you had a hematoma, but maybe your vital signs were okay. They may put you somewhere towards the top, especially if it's a new hematoma, just from what's going on. But you may not be, the red trauma that just rolled in, that sort of thing. And so you get triaged. Then you're going to go to one of the bays, and again, they're going to triage that to either a normal ER bay or a trauma resuscitation bay. And from there, they're going to start their evaluation. You're going to get an IV. You'll probably start getting some pain meds and get some questions asked, and then get some imaging. And then usually at that point, you're going to start seeing more of the specialists. So you're seeing the ER nurses, a physician assistant, or nurse practitioner, or the ER doc, and then you're going to start seeing, your orthopod or Dr. Doug Berglund or myself, and then that's when we're going to start telling you, hey, here's what you have, and here's what's next for you.
Well, you make me feel confident if I end up there.
Yeah, for sure.
I like dealing with you guys.
Probably the biggest thing we should bring with us is our patients.
Exactly right. Yeah. Well, you are the patient, but being a patient certainly helps. Yeah.
Well, sure. I mean, everything that Steve just told us, it takes time.
I tell you though, if you have anything like Steve was talking about, change in vitals or something that is really acute, you will get immediate attention, and those are the ones that run to the OR. That fortunately doesn't happen very often, but if we see that, we're geared for that. We have stuff in place for that.
Well, summertime is the time when, as you said in the beginnings, this is when the traumas begin.
800 out of 1,200 of
Yeah.
them during the summer months, huh?
So,
It's a busy time.
well, it's like the guy on television said, be safe out there.
Yeah, that's
Right on.
right.
Okay. Dr. Steve Satterly, Dr. Doug Berglund, as always, thanks you guys so much.
I think always a pleasure.